Good afternoon, everybody on the East Coast, and good morning to those of you who are joining us from other parts of the states. I do know some of you are in California, and so welcome, and thank you for taking time out of your busy schedules to join us today. My colleague, Dr. Shinoba, helped to develop these slides and this PowerPoint presentation, and he was unable to be with us today, but my other colleague, Dr. Anne-Marie Kimball, will be able to be in the chat box and answer any questions that you may have. So welcome. First of all, I do want to give you a little introduction about myself. Like many of you, I have at some point worked in a rehabilitation setting. I was at a rehab hospital just outside of Boston for 6 years, primarily working with pediatrics, but I did have the opportunity to see some of the inpatients at Braintree Hospital and also to participate in some of the teaching webinars and presentations and seminars that we had there. And for some of you, that's a very well-known facility. And for those of you who are less familiar with it, just to give you a sense, we did have aphasia rounds with such people as Harold Goodglass and Edith Kaplan, along with our own neurologist, Mick Alexander, and Doug Katz. And for those of you who are familiar with Doug Katz, who's an adult neurologist, he is also the current president of the American College of Rehab Medicine, and they have a conference next week in Atlanta, and I shall be presenting there. So welcome, everybody, and I hope you find this presentation on RehaCom of interest. Our agenda today is as follows. We will look at the subject of computerized cognitive training. Why cognitive training and what is the background to it? I will explain that in some detail. We also will look at the different client and patient populations that can be served by the RehaCom program and the role that clinicians play in monitoring and supervising the implementation of this program. We'll look at different distinctive features and how to screen patients. We'll also look at the training modules that are available with this program that involve attention, memory, executive function, and visual field. It can be used not just to assess individuals, but also to provide therapy, and as a result, you'll be able to see how you can extract data about their results. We'll briefly review research on this program, as well as how to operate it, and we will summarize and conclude. The first thing I would like you to all know is that the RehaCom program came from a group in Magdeburg, Germany, called Hazomed. And they created this program almost 25 years ago. It was developed primarily for clinicians. So when you think about where did it come from, how long has it been around, what's the background to it, the answer is it came to us from Germany. From the outside, it was a computerized cognitive training program, and they decided that there were different areas of training that were really going to be important to focus on. Visual field. One of the points I would like to make here is that when I went to a conference, actually at North Carolina, with a group of athletic trainers, and we were discussing head injury and concussion in student athletes, a neurologist who presented said, one of the overlooked areas for individuals that sustain a concussion or a more severe type of head injury is a visual field neglect. And so this program does offer both a screening as well as treatment and programming for individuals that may have problems with their visual field. What is curious, as you may know, is that people may be unaware that they do not have a good visual field. They may be able to see very well on one side of their visual field, but not so well on the other. We'll look at the whole subject of attention, as well as memory and working memory. And what we do know is that there are many individuals that will sustain a head injury, or who may have had stroke, or perhaps a degenerative disorder, that will experience an attention problem and possibly a memory problem too. So these are very common disorders. We'll also look at the area of executive function, and you'll be able to see then that the program will screen for that, as well as provide 22 configurable training modules. One of the features that I will expand upon is that the program does auto-adapt to the ability or level of the patient. Also, for some patients who are impatient, you may find it has a very low level of training because some patients have a very severe cognitive deficit and they do require a very easy level to be able to commence this program. I did speak to some therapists one time who said, oh no, this program's too hard for our patients, unaware that you can start at a much lower level than where they were. So it can be done with patients who have only recently been admitted to hospitals with a head injury, and some of the early research was really based on that patient population. So who are the patients? What clients would benefit from this? So who can it be used with? If you have patients that have cognitive deficits, they may be as a result of degenerative neurological disorders, for example, multiple sclerosis. It may be that the patients had some kind of a brain injury of a traumatic nature. They may have had a CVA or stroke, or some other clinical condition that impacts cognitive function in an adverse way. Now, what you may find is that the deficits of those patients may range. They may be mild or they may be more severe, and you can use the program with a wide range. Now, I was talking to one hospital, and the staff said, you have to understand that we have a lot of college professors, we have physicians and lawyers, professionals who have been the subject of either a head injury or a stroke, and for them, we need to have a program that will be challenging and perhaps won't be typical of other patients. And so it really does range. And you will see, as you look through the program, that it can be very challenging even for those who have not had any kind of an injury. Now, what kind of training can be provided? It may be able to restore or compensate for the type of injury or insult that the patient's experienced, and as a result, it may be very helpful to that patient and their family. Typically, these clients will work in a clinic or hospital setting, and often is in a rehabilitation setting, particularly in the United States and Canada. Now, it would be important to note that in some other countries, like Germany, some patients are able to do work at home, but in the United States, currently, it is configured so that it would be part of either an inpatient or an outpatient rehabilitation center where it can be properly monitored by clinicians. So who would actually deliver RehaCom? The answer is, it is clinician mediated. It can only be accessed if you have a clinician engaged. So we don't sell directly to the public. This is not something that can be done at home by a family just because that's convenient and they just want to be able to access it. It has to be mediated by somebody who's properly qualified. What are those current processes that you're currently using? Do you have patients that have deficits in attention, working memory, visual scanning, or executive functions? Chances are that's a relevant population for their RehaCom program. Some of these individuals may be children or adolescents, they may be adults or even older adults. And when you think about problems with attention, of course, that's both auditory as well as visual. And when you think about visual scanning, we're referring to, do they see their entire visual field or just one part of it? And do they have trouble formulating plans, prioritizing, organizing, coping with the demands that we would consider executive functioning? Do you have patients that have degenerative disorders? in many rehab facilities, that is the case, that although they may not be formally diagnosed, we know that many of them will come into the facility with a disorder, which may then become more extreme as we get to know them, or perhaps as they deteriorate over time. We may also see that they have an acute onset, perhaps a stroke or a TBI, and we may even find they have other conditions such as an attention deficit. Certainly, children, adolescents that have an attention problem may be diagnosed as ADHD, but even if they don't have an attention problem, they may still experience problems with their working memory and executive function, and they may be diagnosed ADHD. So this is a program that may be quite helpful to them too. However, that's not all. We're not just talking about patients that may be seen by neurologists. These are patients that may also benefit from the program. And I have occasionally talked to clinicians who said, I just see schizophrenic patients. I only see individuals in a hospital setting that have a psychotic disorder. And I can share with you that the first 8 years of my experience in the Waltham area was working with individuals that were diagnosed psychotic and in some cases schizophrenic. And I can completely understand why you would want to have a program that could help them. Of course, what we know is that sometimes there's a combination of disorders, and some of the researchers even explored that. One of the articles on RehaCom looked at individuals, particularly adolescents and children that had had both brain injury and ADHD. So sometimes there's a combination. Now, there are disorders in attention and memory, but we may see some patients struggle with the visual field, and many patients that have attention and memory problems also experience executive dysfunction. But not just that. We also see sometimes a reaction to neurological problems such as depression and anxiety. I know there are often times when a person's had an acquired brain injury and they may become quite depressed and anxious about their performance as a result. One of the symptoms or sequelae would be that they react to their disorder in this way. But we also realize that sometimes individuals may present with depression, unaware that there may be some neurological or degenerative disorder associated with that. I've sometimes seen that elderly patients that go on to exhibit mild cognitive impairment and sometimes Alzheimer's dementia may present initially as having depression. So the question might be, is it relevant for individuals whose primary symptoms appear to be depression and anxiety? And the answer is it can be helpful to them too. So it is clinician mediated. We don't sell to the public. We do think it's important for the public to know about this, but this was decided a long time ago that clinicians needed a computerized cognitive program to assist their patients. It was developed for them from the very beginning. So why does this all matter? The simple answer is fidelity. We want to make sure that individuals that do have a diagnosed disorder get help. And what we know is that if it's self-administered, there's a tendency not to finish. Adults frequently have lots of reasons why they're unable to complete a program. And they may be very good reasons on the face of it. For example, jury duty, or perhaps planning a wedding, or perhaps there's been a death in the family and they have to put everything aside. But what we also know is that sometimes we give ourselves excuses to allow us not to complete some program that is very challenging and perhaps hard work. So there's a problem with fidelity. Did you do what you needed to do over the time period that was required? And the answer is often no. That alliance, however, that clinicians have can be very helpful. We know that there is a therapeutic alliance that clinicians, whether it's an OT, a PT, a psychologist, a physician, may have with their patients that's very important. That facilitates engagement and it allows the person then to do the computerized cognitive training knowing that someone is watching, that they care, that they want the patient to do well, and they're encouraging them to persist at it. We also want the relationship to take into account that the cognitive training may be in the context of a more severe disorder. So is that all you need? Is it sufficient? Is that enough? And the answer is no. Individuals listening to this webinar must realize that this is perhaps a piece of the puzzle. It's not viewed as a standalone treatment, and we are not arguing that. When I went to one hospital, they said, well, I guess you don't need us. This is just a standalone, and the speech or OT don't need to be involved. And the answer is that's not true at all. Expertise by experienced and empathic clinicians is vital to ensure that the program is managed and that there's oversight to the process. So what we're saying is this is a component of what you can offer to your patients. It is not sufficient, but your role is necessary. Also, it allows you to be able to automate some elements, and it may create both efficiency and efficacy. We're not adding to your time. Rather, what we may find is that we can help you do your job and save some time, particularly in such things as note-taking or record-keeping or the ability to monitor a patient's performance. So by automating some of those elements, you then can be freed up to do other tasks, and it allows you to become efficient as clinicians. Also, accessibility. Because there's more time and opportunity become available, there are different aspects of overall treatment management that allow you to be engaged and to be able to perform your job. So, disorders like traumatic brain injury, stroke, acquired brain injury that require a comprehensive approach may include physical therapy. I had a young man once who was hit in a motor vehicle accident, and he required very intensive physical therapy when he was on an inpatient basis, and he continued to require it as he went back to school. And he needed the therapy in order to be able to become more independent and self-sufficient. And we know physical therapy can be wonderful for a lot of patients. Also, that's my view about occupational therapy. I think of OT as a wonderful tool for individuals that have had different types of disorders, in that it enables them to accomplish different tasks. Psychiatry may be involved, particularly when it comes to medication management, as well as speech and language therapy, particularly in such things as recognizing how language and pragmatic language in particular may change as a result. I know one time that I had an adult referred to me because what he wanted to say and how it came across was sometimes very different than the experience that his family members had. And he didn't understand how he was aggravating, frustrating others, and it made him more labile, and he would tend to have a very short fuse, and consequently he would provoke arguments, unaware that it was his own interaction that led to some of that difficulty. And so for many patients, speech therapy is really an urgent and important part of their treatment. So treatment does require a comprehensive approach. And in any one particular case, there may be a variety of different clinicians. And consequently, any one of those may become the mediator for the RehaCom program. This is a program that is used a great deal in Europe by OTs. It can also be used by speech and language therapists, because there are parts of the program that may be very appealing to them. And again, when I've presented this in hospitals, the speech and language therapists seem to be on board before some of the others around the table. They've heard about this, they know they want this, this is going to enable them to accomplish certain tasks, and they see the value, and I appreciate that. Psychologists And again, neuropsychologists may play a role. And I think it's important to recognize that in places such as Germany, or for that matter the UK, the psychologists may play a very different and a pivotal role than they may in some hospitals in the States. So, for example, in Germany, it might be the neuropsychologist that will consult with the physicians, particularly after a patient's had an MRI or a CT scan and other work done, and they may then determine what types of programs may be appropriate for patients, who's going to provide some of those, and so they may play that role of mediating, monitoring, and overseeing service delivery in an inpatient setting. And one of our clinicians in Germany was sharing with me, he's done this for the last 20 years, and he has seen several hundred patients where the RehaCom program has been provided, and then he has his own insights and observations about how he can adjust the demands and the, let's say, the parameters of the program for his patients. In the States, we may also have physiatrists involved, and physical therapists, as I said earlier, physicians generally, and other important clinical staff can all play a role in mediating the implementation of this program. Now, what makes it different, and why does this matter? Well, the program was initially developed 25 years ago by a psychologist in Germany called Dr. Weber and his colleagues at different hospitals and facilities. And since that time, it's been updated and revised. This was a tool developed for clinicians. And so when they were frustrated by something, or they needed to see something improved or changed or expanded upon, that feedback was incorporated and other components were developed. So it's reflected in the range of training areas, in the breadth of training that's currently available, and how it can be configured. So we wanted to let you know that its relevance has really been tested over that quarter century in Europe, and we can now benefit from the fact that clinicians have been involved from day one, saying this is what I want to see changed, and if you can incorporate that, it may be more useful to me. So there are a broad range of training areas. This is not just a program that looks at one distinctive thing, such as working memory. It explores areas that are important for patient care, such as attention, executive functioning, and visual scanning, which may otherwise be overlooked. So its breadth is important, and it has a range. Now, it also has a breadth in terms of very low levels for the severely impaired patients to rather difficult levels for those with much milder problems. So if you had an adult that may have been at a very high professional level in their career who's experienced some reduction in their efficiency, you may still be able to challenge them and work with them because it will challenge even the brightest amongst us. The other thing to be aware of is that there are ways in which you can change the training that's being offered. Now, I understand from clinicians in Germany that a lot of times OTs will just leave it as is. And that reminds me a little bit of a Mercedes car where you can have it in automatic and you don't need to worry about what gear am I in unless you want to go backwards or just park. And if you rely on the automatic feature of the car, you'll be doing quite nicely. And so some of the programs are just like that. They are auto-adapted, and they are configured by the computer for you. However, you may also decide, I want to get out of that automatic approach, and I want to be able to change some of the parameters. I want to refine the treatment. I want to prioritize different areas. I'm going to make it harder. So, for example, you might say, I want to take out language that involves instruction, or I don't want to have to repeat the instructions over and over. I want to take out the cues so that when they get it wrong, I don't want them to know that. So, or let's change the exposure time. So, in a way, when you're moving away from a more auto-adaptive version to a more refined, specific version, that's something that the psychologists and neuropsychologists, those clinicians, seem to prefer to do in Germany, because then they can really understand what they're asking their patients to do and adjust the demands that are confronting them. So it is configurable. Now, what does it offer? The answer is you can screen. You can screen in different ways, and you can get a baseline measure. You can also see if that's where the patient is today. That's a reference point that we can then use to guide our training, and we can see what screening modules might be needed, what additional assessments might be needed, or what other therapies might be appropriate. So it allows us to figure out, where should we begin? Let's say the patient presents as having an attention problem. How bad is that? What does it apply to? What kinds of tasks does the patient have a problem with? And we can figure that out. Also, the program will adjust according to the performance of the patient. So, by using live feedback, it will semi-autonomously figure out what the training levels should be. And as I said before, you, the clinician, can change that. But often, it's been found that therapists like to have the computer determine what the difficulty level should be. It's less work, and it's not something they want to do. Then lastly, reports can be provided, and this includes graphs and numerical data, and those objective data can then be exported, printed, and entered into medical records, so that it allows you to then be able to say, this is what the patient's been working on, this is how they're doing, and you can then see this is how they did today, this is how they compare with previous days, this is my goal, and this is how far they are in achieving that goal. So it is auto-adaptive, and it's individualized to the particular patient that you have. What does that do? Well, it makes the training effective and easier to tolerate. The patient doesn't feel like, I'm frustrated because I'm not getting where, I can't do this, this is too hard. What it does instead is it makes it easier, and then day to day, as the patients change, perhaps there are good days and bad days, the program can adjust as well. You can decide where you want to start, and you can then be flexible. So there's a range of options that are offered to you, the clinician, to then decide, where do I begin? It also allows you, as I said earlier, to be more effective and perhaps more efficient. So those lower levels of training that are really important to patients that have severe deficits, it can be helpful for them to start. And I know it can be so frustrating for family members and loved ones to say, there's nothing that can be done for my son, daughter, husband, wife, relative, because they are so severely injured. Nothing is going to be helpful. And the answer is, this does go down to a pretty easy level, and it was determined that patients that are more severely impaired also need to have shorter periods of time for training, perhaps more frequent, so they may have 2 or 3 per day, and then they do what they can manage, and they will build up their energy level or their ability to tolerate fatigue and attention. However, for some patients, you need things that are challenging, and it does offer that. So there's a broad range. And we do suggest, try the program out yourself. Now, one of the things to also be aware of is that there is a unique keyboard which is provided through RehaCom that makes the tasks much easier. So you don't need to get the keyboard. However, it was designed to make the training and the screening much easier for them, and this is available through us in the United States if you so desire. So you can press the OK button. There are right and left buttons. And let's say you have a patient that is a dyspraxia or they have a dysarthria and they're having trouble, this might be ideal for them. Some patients don't need it. That's fine, but I can tell you it makes the task performance so much easier when you use the keyboard, which has a accessibility to a broad range of patients, and it also has a little USB port on the underside, which will plug into your computer. So there are screening programs. As you can see below, in the area of attention, there are such things as alertness, vigilance, spatial, selective, and divided attention, and visual attention. And so as you look at those modules, you might decide, okay, this patient seems to be at a pretty low level, so I'll start with attention and concentration. So screening is a very good place to start. You can identify what the deficits are for a particular patient, and that's going to guide what you do. Then the training is flexible, and you can start with any module. This program does not determine for you what you should be doing. However, it will guide what you may want to focus on. And in some areas, let's say there's a problem with alertness and attention, you may need to start there. Also, it allows the clinicians to approach the training as they see fit. What do they think needs to be accomplished? So there are 22 training modules once the screening has begun. The same principles and the structure apply to all those modules, and it does allow the training to be faster and more intuitive. Let's review the screening modules. On the left-hand side, you can see the module name, and on the right-hand side, what does it do? So in the area of attention, you're looking at alertness. Does the patient react? How responsive are they? And it will measure such things as how quick they are. How long do they take? Can you pay attention to the stimuli that have been selected? And can you divide attention between different tasks? Can you also visually scan and find certain numbers? And can you selectively attend as you're doing that? So those are attention screeners. In the area of memory, you're looking at words and working memory. And working memory is defined as not just the registration and repetition of auditory or visual input, but rather the ability to problem solve, take into account items that may have had to be held in memory for a short period of time. So it's not just recall, it's using stimuli to actually problem solve. We look at logical reasoning, and then in the visual field, does the person scan? Can they see the entire screen? And as a result, they might require saccadic training, also visual field. Now, I spoke to an ophthalmologist recently about this, and he said the way I define saccadic eye movement training would be the ability to form a three-dimensional image by moving the eye or perhaps the head to be able to consolidate visual data. And you'll see that when you do the saccadic eye training on the RehaCom program, that there are different components that are being identified. So these are the screening modules. You are looking at tonic and phasic alertness. Can the person react? Can they divide attention between visual and auditory attention, particularly when both are being presented at the same time? Can you select what you need to attend to? Can you visually scan? And are you actually missing an area of the screen? And I recall when I was doing testing of inpatients that you might ask a person to draw a clock face or perhaps a bicycle, and you pay attention to how detailed was one side of the picture versus the other. Were they glossing over certain features? Was it kind of there but vague? Or was it just not seen at all? And I haven't forgotten the time when a patient came in to see me who'd shaved on one half of their face because they just didn't seem to see the other half. So that's an area that certainly we can screen for. When you look at verbal learning ability, is the patient able to recognize recurring figures? Can they read and store words? Can they hold on to that information? And can they identify regularities? Can they see a series and draw conclusions about that? And can they also look at different parts of a visual field, keep their mind on what they're doing, and answer the question. So those are some of those modules. Now, let me walk you through this. Once the patient has done the screening, this is the results. So the first thing to note is that you're going to get a bar graph, and it's going to be superimposed on scores. So right here, this is the normal area. Let's see if I can use something to identify that. Here we go. Let's do, how about purple? Will that do? So here is normal. Let's find another one that actually shows up. Let's do the laser pointer. There we go. Right here. That's normal all the way down. And this would be above average. Now, how far away from normal is it? Well, here's one that goes all the way down here. So you can see it's color-coded. Because in the green area, it's up to 1 standard deviation below. So for a T-score, that's from 50 to 40. But if it's 2 standard deviations, we go down to 30 and then down to 20 and even lower than that. So here's a person who in a working speed spatial number search task is having major problems with their speeded performance here and also here. So this is way below where it should be. This is the normal starting point. Now, spatial number search for sustained attention is within the normal range here. And is there evidence of neglect or hemianopsia? Is there particular blindness on the right or left side? Again, it's going to be slightly out of the range. So these are color-coded and numerical. And what we can say is that you can have scores that will characterize that person's performance with percentiles, Z-scores, T-scores to help you figure it out. In addition to that, we can look at the different training modules that may be recommended. This person's really having a problem, therefore attention and concentration in parentheses or in brackets is suggested in some cases. And then a discussion. The results are summarized to the left of the graph, and where you start off as having an average or normal sample, it is color-coded. So red would show this patient's performance is more than 3 standard deviations below the norm. So that's not good. So we can see the details. You can print this if you wish. You can export it. You can also close out of it. And the gray bars denote deviations from the norm. So once we've screened, there are training modules that you can then get into. Attention is implicated in a large number of disorders of patients that we see, perhaps as many as 80% after a CVA or an acquired brain injury may have an attention problem. So we know it's pervasive, and we know that it may present with other disorders. So what the computer might do is say, this patient should start with selective attention here. There are 24 different levels. Here's a recommended starting point. Now, if it's too hard, you can go to a much easier module. So you can then ask the patient to do alertness training and perhaps vigilance training. So is the person able to react? Are they responding? Are they sustaining vigilance? So once you've accomplished those, you may find that you can then move back into selective attention. If it's too hard, make it easy. However, if it's too easy when you start here, you can do more challenging ones, such as here. You can do visual spatial attention, or spatial perceptual, or divided attention. And these are really quite challenging down here. So this area here is more challenging. This area is more easy. And the computer might recommend this as a starting point, and you can then see, where do I go from here? So here's an example. This is level 6. You can see that here. And what we have to do is match to this stimulus here. So which one of these is like this? And so when you say to the patient, I want you to start here, This is level 6. It goes all the way down to level 1, and in some cases it may even go up to level 23. If it's too hard, go back to an easier one, an easier level. If this is too easy, you can go on to a much harder one. But you can also stay with this and see if the patient can get 100% correct. So you can escape to change the level of difficulty. It's up to you. You're the clinician. You decide. Now, for the easier modules, there are some that look at reaction behavior. Do you respond? Can you keep your mind on what you're supposed to be doing as these are moving along? Then you can look at spatial attention for spatial operations, two-dimensional operations, and three-dimensional operations. And then the more challenging ones are here: driving a train and driving a car. And as you can see, you have to regulate your speed in accordance with posted speed signs. And you may also find that there's a cop car in your rearview mirror, and you need to decide whether you need to go slower in order to comply with posted speed, or whether you need to go faster because you're going too slowly. So the question is, can you take into account those different features in your visual environment and monitor your performance? This, by the way, is one of the more popular tasks in Germany. And as you can imagine, with a number of different patients wanting to resume driving, this may be one area that can be conducted to determine what their reaction time is like, and if they can take into account such things as visual field, and can they attend and sustain attention over time. When you think about, should this patient be driving, this is just one task that you can refer to, and it will help the patients show that they are making progress. Now, this is not the only tool they use, obviously, but when you have the equivalent of an interstate with a no speed limit and very, very powerful cars, it's going to be very important for any physician or clinician to make sure that other drivers are confident, are able to be safe behind the wheel. One of the next areas is called memory, and we have these different aspects of memory, including working memory that has a lot of different components to it, different levels, topological, physiognomic, and so forth. Let's get on with this. And you can see, here's working memory. Can you remember the cards and where they were? Can you remember those picture cards and shapes? And can you remember faces? Interesting thing about physiognomy is, can the person remember the names, occupations, and phone numbers? And when patients really have a problem recognizing, let's say, family members or their own doctors and nursing staff, you can actually incorporate some of those faces into the program. Figures, words, stories, particularly with multiple choice, are all included. In the area of executive function, can the patient plan, reason, and make decisions about their functioning that would be important for them to return to daily routines and their normal life? So these are considered to be more ecologically valid and meaningful to patients. So if they're planning a vacation, what are the parts of it that they need to pay attention to? And then if they're planning to go shopping, what do they need? And in what order are they going to get things? And do they forget what they went out shopping for? So these are areas that may be very important, and the patients can